Do you ever get frustrated by difficult heart views in ventilated patients? There's a tool that helps solve this problem, transesophageal echocardiography, or TEE. By viewing the heart from the esophagus, you avoid the lung and ribs getting in your way. It's easy to learn and uses all the same interpretive skills as transthoracic studies. Let's get into it. I'm Dr. Alex Estelle, and this is SonoCare. A quick word on the patient population we're talking about. This series is on performing a goal-directed resuscitative TEE study on patients who are intubated and sedated for conditions like shock and cardiac arrest. TEE is a great tool with many indications that require extensive training to develop competence. Our focus here is on critical care providers performing a TEE study on patients who are sedated with a secured airway, where probe insertion and use has been demonstrated to be quite safe. Research has found that basic competence in resuscitative TEE can be achieved after as few as 10 supervised studies, meaning that if you have access to a probe and supportive mentors, you can quickly start to incorporate TEE into your practice. It's important to think about which patients should not have a TEE study, specifically those with esophageal and gastric diseases. Tumors, strictures, ulcers, diverticuli, and bleeding are all best left undisturbed. Similarly, patients with a perforated viscus should not have a TEE study. While TEE studies are generally very safe and well tolerated, we want to think carefully about other factors that may predispose our patients to having bleeding or anatomic complications with probe insertion. To make probe insertion easy and minimize injury to the patient, I use paralytics and direct visualization. There is sometimes a little resistance as you move through the upper esophageal sphincter, but insertion should not require much in the way of force. If you are having difficulties, you can perform a jaw thrust or flex the patient's neck to try and help open the esophagus. Once the probe is in the esophagus, advance until you see the heart, which should be around 35 to 40 centimeters. If you're seeing other structures, you may need to rotate your probe to turn and face the heart. A word here on how to manipulate a TEE probe. There are really three movements you can play with: insertion and removal, rotation left and right, and anteflexion-retroflexion. Insertion removal moves the probe up and down in the esophagus. For the majority of our exam, we're going to be at the mid-esophageal level, so we'll only need very small up and down movements to optimize our view. Later in the exam, we'll move the probe into the stomach for transgastric views. Rotation left and right lets us turn the probe, which is essential for finding the alignment for our views. It also lets us look at vascular structures like the great vessels and the aorta. Think of clockwise rotation as looking right and counterclockwise rotation as looking left. Anteflexion and retroflexion are produced by turning the big wheel clockwise and counterclockwise respectively. These adjustments move just the tip of the probe, adjusting the angle of the beam, which is essential for generating on-axis views and ensuring good contact with the lumen of the esophagus. It is important that we let go of any flexion in the probe when inserting and withdrawing the probe to avoid a luminal injury. There is also a small wheel that allows the tip of the probe to move left and right to maintain contact with the esophagus. Perhaps the trickiest alignment to conceptualize is the angle of the crystals, or omniplane angle, shown in the semicircular dial on the screen. The omniplane angle acts like our probe marker does in transthoracic studies, indicating the alignment of the beam of ultrasound waves. 0 degrees places the probe marker toward patient left, with a transverse beam coming out of the probe. Increasing the omniplane angle rotates the beam clockwise, such that 90 degrees has the probe marker facing towards the patient's head, and 180 degrees has the probe marker facing towards the patient's right, essentially a mirror image of 0 degrees. Changing the omniplane angle is essential to creating different cuts through the heart and thereby producing different views. Consequently, the movements we've just discussed will have a different effect on the image depending on the angle of the crystals. In a resuscitative TEE study, we are looking to make 4 views: the mid-esophageal 4-chamber, akin to an apical 4-chamber, the mid-esophageal 3-chamber, akin to a parasternal long axis, the bicaval view, sometimes dubbed rich man's IVC, and the transgastric short axis, akin to a parasternal short axis. We'll get into how to make these views and their clinical uses in our next video. I hope you found this video helpful. Now get out there and scan.